Hello, everyone. Good morning. I am Dr. Uma Srivatsa, Director of Arrhythmia Services at University of California, Davis. I'm also the section editor of the Global Voices in HRO2 Journal. Heart Rhythm O2, Global Voices, publishes research papers in areas of prevention and management of arrhythmia, prioritizing health of vulnerable communities worldwide. Today, we have an esteemed guest, Dr. Gregory Lip. He's the Price Evans Chair of Cardiovascular Medicine, Liverpool Center for Cardiovascular Science at University of Liverpool in United Kingdom. And we all know about Dr. Lip from his various publications. He has pioneered in stroke prevention strategies, ABC pathways, in atrial fibrillation management. So, Dr. Lip, welcome to the show today.
Thank you.
Let me start you off with asking you, we recently published a series of Global Voices section about atrial fibrillation management from different parts of the world. And you wrote an editorial about that as well. And you run the National Institute for Health and Care Excellence funded Global Health Research Group. And you have come across varying findings which might be useful for the audience here. Would you care to take it away and talk a little bit about it?
Thanks very much, Uma. Thank you very much for hosting me on this webcast today. Well, I suppose the starting point is that with atrial fibrillation, we all recognize it's the commonest cardiac rhythm disorder, but it's also a global problem, and it's not something unique to Western countries. I mean, this is clearly also something very much evident in many of the countries in different parts of the world where we have additional challenges, for example, under recognition, under diagnosis, and suboptimal management. And with the Global Voices series, I'm really pleased that it's again highlighted the issues. And in this particular segment, we had covered the situation in Brazil and so South America, and also a segment from Asia, including India and Thailand, for example, and Sri Lanka. And we also had a segment from China, where whilst it's many of the big cities are very urbanized and offer a good standard of care, we also covered the challenges when delivering atrial fibrillation management in rural communities in China as well. So it's trying to comprehensively cover a range of healthcare systems, with which each of them may well have their unique aspects of how they approach the problem. These can be, as highlighted, just simple detection and screening, even high-risk populations. Many of the countries that I mentioned, for anticoagulant strategies, for example, they use warfarin. And even then, it's not just prescribing warfarin. The next challenge, of course, is quality of anticoagulant control. And in fact, the countries that we studied, they find it very difficult to get to a time in therapeutic range of, or TTR of 65, 70% and above. The DOACs, the direct oral anticoagulants, in some of the countries are self-pay, which again brings its challenges again. And quite common, especially in some of the Asian countries, is off-label underdosing, because there's the perception that with the off-label underdosing, there is going to be less bleeding, yet preserving the efficacy, except the evidence doesn't support that either. But anticoagulation is but one segment, or one of the pillars in terms of atrial fibrillation management. The latest US guidelines, of course, verbalize this as the SOS, in terms of avoiding a stroke, the other comorbidities, and also the symptom management, particularly rate control, rhythm control. In terms of evidence base, it's the ABC pathway, the atrial fibrillation better care pathway, which actually is in the guidelines from the 2020 European Society of Cardiology, plus also in a number of Asian guidelines from the Asia Pacific Heart Rhythm Society, for example, as well as the recently published China elderly AF guidelines as well, or AF in the elderly guidelines, not elderly guidelines, AF in the elderly guidelines, where because of the evidence base, and some of that is from Asian countries. And what does the A and the B and the C stand for? Well, A is avoiding a stroke, where the default is stroke prevention with anticoagulants with a preference to the DOACs. The B is for better symptom management with patient-centered, symptom-directed decisions on rate and rhythm control. And the C refers to comorbidity and risk factor optimization, including psychological morbidity, including lifestyle type factors. And of course, across the way, we have to reevaluate each of these.
Right. So, Dr. Lip, many of these, you and I live in a different world here. So many of these countries face the challenges of transportations, access to care, and even like health systems, right? Like many of them, as you said, they pay for service. Yours is much better. It's a, nationalized health services. Even we are having these challenges in the United States about coverage and, millions of people without coverage, et cetera. So, and definitely globally, that's a huge problem. And how can the patients globally overcome that? That's one question for you. And then second question I have is, you have highlighted the Cool AF registry, the Impact AF registries. So how can physicians, irrespective of the healthcare systems or the government funding, rise up to help the patients they're caring for?
I think that's a great question. I think the starting point, firstly, is to ensure a uniformed approach to advice and education. That and in a sense, is to again try and pitch it that the allied health professionals, particularly, and in many of the rural, particularly in the more rural areas, are delivered by allied health professionals rather than medically qualified individuals. That atrial fibrillation sometimes is perceived as a very sort of esoteric and difficult to manage, but I suppose the messaging really is common, and it is managed by a whole range of healthcare professionals, primary care physicians, and many non-cardiologists and cardiologists. And you mentioned a number of registries, and I'll come to, and they by and large highlight the issues because in terms of the investigation and the risk factor management and the application of evidence-based therapies. So we actually did test this in rural villages in China, and this was a cluster randomized trial. This was called Miracle AF, which was actually presented as a hotline trial at the European Society of Cardiology Congress in London in August 2024. What was Miracle AF? Well, this was going to actual rural villages where the medical care was delivered by so-called village doctors, who many of whom were actually not medically qualified. So the starting base in the cluster randomized trial was that then there was a period of enhanced education and advice on the simple measures that a non-medically qualified provider can actually understand on atrial fibrillation management can be easy. Well, relatively easy, shall we say. So you could say it's enhanced, that's the sort of baseline. So, or rather you could say that's enhanced usual care. And that was compared to enhanced usual care plus the village doctor delivered ABC pathway face-to-face, supported by telemedicine. So the specialists at and the coordinating center was my colleagues, my collaborators in Nanjing. But then again, there were other sort of you could say central points which were providing the telemedicine support. What the cluster randomized trial showed was that the intervention, in other words, enhanced usual care plus village doctor delivered ABC pathway with telehealth support, reduced the primary outcome by about 35% in favor of the ABC pathway compared to enhanced usual care. And there was also a significant reduction in stroke. There was also a significant reduction in hospitalizations. And in many of these healthcare systems, the primary healthcare costs is actually related to high risk of hospitalizations associated with atrial fibrillation. So I should point out that the Miracle AF followed on our previous cluster randomized trial called MAFA that was done in the big cities particularly, and it was the ABC pathway delivered by mHealth technology, so through a mobile phone app. So the criticism was that, well, it's not applicable across the board because not everybody has a smartphone with an app, because that was done in a healthcare system where mHealth was very prevalent, and mobile, you can go shopping for a newspaper. They don't want your cash. They want your phone to tap on their reader just to pay for a newspaper. Yeah.
Oh, you would be surprised. I mean, in India, when I traveled, roadside vendors have the QR code for paying, for people to pay
Yep.
via GPay, etc. You'd be surprised.
No,
So,
absolutely. Yeah.
yeah. So, on that thought, you said there's a 35% improvement in clinical outcomes and hospitalizations. I mean, one of the things that is subtle is like, what is the age group of these patients? Is there a high prevalence of rheumatic atrial fibrillation as well?
Mm.
And how does it affect the economy, right? Like for a family, as well as years, the dailies, productive living component of their lives. And that must have a huge impact.
It will do. And for the two trials I mentioned, those were largely what was so-called non-valvular atrial fibrillation. That's the old terminology, you could say. But many of the other countries, like the registry work that we've been doing, for example, in India and Sri Lanka, yes, valvular atrial fibrillation is prevalent. But by and large, the underpinning principle is that atrial fibrillation management requires a holistic or integrated care approach. And it's also worth highlighting that the atrial fibrillation population is not a homogeneous single group of patients. And our analysis from Kerala AF, which was one of the India registries, actually it should be online in the Lancet Regional Health Southeast Asia, where we actually look at clusters of comorbidities. So in Kerala AF, what we did show was the patient population could be segmented into certain phenotypes, and each have a different category and unique clinical features, and that has implications for their prognosis. Whilst that was not a trial, that was basically an observational cohort study,
Right.
we also investigated the impact of ABC pathway compliance in relation to those clusters.
Interesting.
And actually, we did show that irrespective of the clusters, there were clearly higher risk categories where the benefit was, you could argue, numerically much better. But the message for the composite clinical outcome was that adherence to a holistic or integrated care approach based on ABC pathway criteria was associated with better outcomes in the Kerala AF. So, it's evidence, not eminence, when you come to the ABC pathway.
Right. No, absolutely. And many of these countries, really doing a randomized trial is really impossible. We have to look at these registry data, observational data. Well, I want to thank you very much for this wonderful interview and your work in stroke prevention across the world. And as a final thought, I want to ask you, how does your work you feel is making an impact or inroads into the care of these patients across the world? And I want to put a plug in for our journal here. We welcome such data from across the world.
Thanks, Uma, for your kind words. And indeed, I think it's actually personally very satisfying that we can put the message out on how to manage atrial fibrillation in a simple and uniform manner across the board. And it's not just a disease it's not just a condition in well-established, sophisticated healthcare systems. We are dealing with a global problem. And what we have indeed tried to raise the awareness that atrial fibrillation is more than simply anticoagulation. And we see now again, there's the ABC pathway written into Brazil, the sort of you could say the care pathway, because as part of the NIHR Global Health Research Group project, we actually did pathway mapping in terms of how the patients from diagnosis up to ultimately being seen and managed by healthcare professionals. Same thing in Sri Lanka. We also did the pathway mapping for these patients. And in fact, there was extremely good community engagement involvement in Sri Lanka, to the extent that even when the project concluded, it is still going on, where they have regular sort of dialogue sessions between the team, the research team, or as part of their medical care. In some ways, it's nice to see how this has progressed on a global scale. When we started the work, one of my fellows did a systematic review on epidemiology of atrial fibrillation and its management in loosely calling it non-Western countries. I mean, out with Europe and out with the Americas. And there was really very little published at that time. This is going back now about 20 years now, I'm afraid, showing my age now. Then we had a subsequent fellow repeat the exercise about 10 years ago. And almost, you could say, the epidemiology was substantially increased. I'm not implying for 1 second it's related to the awareness or some of our work, but the fact that there's the greater recognition, this is a problem on a global scale. And now, if you start looking through the literature, tremendous amounts of work coming from many of the emerging economies, and absolutely delighted. The message now is, yes, we may know the epidemiology. Now we just need to implement solutions and pathways from their management in a simple and easy manner, almost easy as ABC.
Absolutely. We are partners in this, and let's hope that we can make this world a better place to be in our own unique little contributions. And thank you very much, Dr. Lip, for being our podcast or video today. And I want to thank the audience for their time in listening to this wonderful person who has been doing a lot of research and improving the care around the world. Thank you.